welcome everyone. My name's Philip De Croo. I'm delighted to be able to chair this session, and I would like to open the session by acknowledging the traditional owners of the land on which we're all joining, acknowledging that it's different for everyone. Today, I'm actually joining from Port Moresby in Papua New Guinea, and I'd like to pay my respects to the Papua New Guineans and their elders and leaders, past and present and emerging, who have been extremely hospitable to me in the 3 different places I've been travelling rapidly, but also acknowledging all the traditional owners in the different lands in Australia from which people are joining as well, and acknowledge that the lands were never ceded. With that, I'll hand over to my co-chair for this exciting session. And I would say one of the topics that's come up the most while I've been looking at TB programs here in Papua New Guinea is counselling and patient support. And what do we need to do? Because there's a lot of issues. So people are going to be joining and looking forward to this presentation, Beth. But over to my co-chair, Dr. Gail Cross.
Hi, everyone. Thanks for joining us today. So Beth is a wonderful ID trainee, an advanced trainee who's currently at Austin Health, but she took last year off and did a Diploma of Tropical Med, the Gorgas Course in Lima. She's also done her honors research project in dengue vaccine development. So, and now she's working with us on a project which is looking at treatment support in clinical trials. So she's doing the full breadth of both highly translational science dependent research all across to social protection policy in healthcare, developing a nice breadth of, I think, experience and research. So it's my pleasure, and thank you, Beth, for agreeing to present at the Regional TB Journal Club today. I'm very excited about this topic. It's something that's close to my heart because whilst I think biomedical interventions are very important, I think that we've ignored social policy in health for too long in TB. So over to you.
Thanks, Gail, and thanks to Phil. I think I need to sort of thank Gail in particular for being a bit of a PR manager for this talk. But I will start now. So I guess the question that we're going to be answering today in this journal club specifically is, can socioeconomic interventions improve TB outcomes? We'll be looking at a randomised control trial, specifically speaking to conditional transfers, cash transfers, and TB counselling in South Africa. So just a brief overview, I'll give some background, particularly looking at some of the World Health Organization frameworks over the past few decades. Then I'll be speaking to the Journal Club. And then just right at the end, I will give a brief synopsis and some results of a systematic review I've been doing with Gail and Phil and April Holmes at Burnett. So as I've said, there's been a number of World Health Organization frameworks over the past few decades that have focused on TB control. So in the early 90s, there was the DOTS, or Directly Observed Therapy Short Course framework, which really focused on treatment delivery and adherence, as we all know DOTS today. And then moving into the early 2000s, there was the Stop TB framework, which really focused on the scale up of existing TB clinics and integration of TB and HIV clinics together. So prior to the now End TB strategy that was introduced in 2015, most of these frameworks really predominantly focus on the biomedical approach and program expansion. So NTB really represents a broader shift towards sort of more patient-centered and socioeconomic models of TB care, who self-describes it as a blueprint to end the TB epidemic by 2035. So they've got some pretty bold targets, including a 95% reduction in TB deaths, a 90% reduction in persons being affected by TB. This is all compared to 2015. And a complete eradication of families and persons being affected by the costs associated with TB. So the NTB strategy really focuses and recognizes that sort of things outside of the biomedical model, as in poverty, healthcare costs, housing instability, food security, and access to care, actually really, in fact, are major determinants of TB outcomes. So the strategy focuses on sort of 3 key areas, or pillars, as they call them, to improve TB care. So we have sort of focused around pillar 1 and 2, which is about emphasis on patient-centered care and supporting systems and policies that surround this. So that kind of moves us to the topic of this journal club. And I did get a question online prior to doing this, which was, why did I choose this paper? Which is a nice, simple question. But the reason I chose it is really just to demonstrate the significance of the socioeconomic interventions, or treatment support interventions, as we call them, on TB outcomes. So I'll speak to it a little bit later on when I talk through our review, but over the last sort of 12 months, Gail and I have read more than 70 randomized control trials on tuberculosis, and very few of them have actually focused on socioeconomic interventions. And I think that this study has some really important discussion points, and hopefully that can sort of create discussion at the end. So this is a study that was published in Lancet Infectious Diseases at the start of February last year. It was published by a number of colleagues in South Africa. That was funded by both the South African and United Kingdom Medical Research Council. So a bit of context about TB in South Africa before we go into the paper. So South Africa has one of the highest burdens of TB in the world. It represents about 3% of global cases. So it's been evident over the past few years that there's been some pretty good improvements in TB outcomes, but there's still some pretty big gaps. And so the authors of the study recognize that while there's been these gains, there's still a number of people who are diagnosed with TB that actually don't get started on treatment. And this sort of pre-treatment loss to follow-up group is as high as 25% of diagnoses. And qualitative studies in South Africa and also other sort of similar income settings have suggested that this is also often related to the costs associated with TB. And it's been sort of explored and shown that this pre-diagnosis period is probably the most costly, and this is due to loss of income from illness, hospitalization, delay to diagnosis, getting the right tests, etc. So in spite of this being such a big problem, there's been really limited RCT data exploring these socioeconomic interventions. And the trials that have tried, there's been a few over the past few years, they've been pretty significantly critiqued about the fidelity of the intervention. So whether or not people actually were able to get the cash or get the food. And this makes the scalability of these interventions come into question as well. So moving to the paper itself. So this was a paper that looked at the adult population who were specifically undergoing investigation for pulmonary TB in Johannesburg. The intervention itself was a bundle. So it was a combination of pre and post-test counselling, as well as a conditional cash transfer. They compared it to just the standard of care, so no intervention bundle, which was as per the national standard in South Africa. And the simple outcome or hard clinical outcomes of successful versus unsuccessful TB outcomes at the end of treatment. So as I already said, they only included the adult population, and these patients had to be undergoing investigation for pulmonary TB. They excluded people that were already diagnosed with TB or those that had a clinical diagnosis and were already on therapy. And then importantly, they also excluded people that were anticipated to be relocated during the duration of the study. And while it wasn't a specific exclusion criteria, this essentially meant that all drug-resistant tuberculosis was excluded because patients who were diagnosed with MDR, XDR were transferred to other clinics. And so they were sort of just subsequently not included in the trial. So the methodology itself was pragmatic, it was multi-centered, it was randomized, it was in 9 Johannesburg clinics, and they used block randomization as a 1-to-1, which was, and they stratified by clinics, or the 9 clinics. They use allocation concealment using just the opaque envelopes on randomization. And I think importantly, while it was an open label design, because you can't blind for cash interventions and you can't blind for counselling, they still did blind the assessors and the people that were doing the statistical analysis. So speaking to the actual package of interventions that they used, it was a counselling, pre and post-test counselling approach that was sort of based on the previous HIV model of using HIV pre and post-test counselling. So they had about 10 to 15 minutes prior to taking the test, where they spoke to patients. This is, sorry, on the right here is one of the pamphlets that they were using. So they spoke to the patients about what TB is, how it's transmitted, what the tests are involved, and when they would expect results. And then those patients that were randomized into the intervention arm and also then subsequently tested positive underwent post-test counselling, where they spoke to the patients about the interpretation of a positive result and how they would undergo treatment and the importance of adherence and infection and control during that time. So similarly to the post-test counselling, if patients were found to be positive by GeneXpert, they were eligible for 7 conditional cash transfers. So that was one at diagnosis and then subsequently every other month until the end of their treatment. So this totaled about, so it's 150 Rand or a total of about 1,050 Rand. So the transfers were conditional of them attending their appointments with the sort of 7-day buffer either side of the appointment time. So the way that they did it, as opposed to just giving cash straight, they either did mobile banking for those that actually had bank accounts, or for people that didn't have bank accounts, they used a ATM card. So patients could actually take the card themselves and go straight to an ATM to withdraw the money. And I just wanted to sort of describe what 150 Rand is. So that is about $10 US or about sort of 12 to 14 Australian dollars. So in South Africa, it can buy you 1.5 Big Mac meals, according to my Google search. But it also just means it's probably about a top up of a grocery shop, which can be significant for many people undergoing investigation. So speaking to the primary outcome, it was quite a simple primary outcome model, which is just a proportion of successful versus unsuccessful outcomes at the end of treatment. So successful being cured microbiologically or completed treatment as a surrogate for cure. And then the unsuccessful outcomes were standard per a TB treatment efficacy trial, loss to follow-up, development of drug resistance, treatment failure, or death from any cause. But I'll just draw attention to the pre-treatment loss to follow-up group, which is reasonably unique for this trial, which meant that they included people who didn't actually start on treatment, which is often, I guess, missed in a lot of trials because they're only looking at people that are on the drug treatment that they're using. There was a few secondary outcomes that were described in the data collected for, but they weren't actually reported in the study, and I suspect there'll be more studies coming out of the data set that they have. To calculate the sample size, they used baseline data from the year prior to collection. So in 2017, they looked at the number of people undergoing investigation for pulmonary tuberculosis and found about 10% actually had a microbiologically confirmed case. And then in order to get enough people to have the 80% power, they calculated that they were going to need 960 microbiologically confirmed pulmonary TB patients. So that meant if they only had 10%, they needed a sample size of about 10,000 with that allowed for a 15% attrition rate. So the statistics were not very complicated, but I just want to sort of draw to the 4 main concepts that they used. So the first being that they used a modified intention to treat analysis over an intention to treat analysis. And that's because the intervention is only intended to be used for people that were actually subsequently diagnosed to have a microbiologically confirmed TB case. So it's slightly less rigorous, of course, than a true intention to treat, but these exclusions were predefined. They use a regression model with robust standard errors to estimate relative risk for a number of variables for unsuccessful outcomes. And then I'll speak to it in a little bit more in detail in a second, but they use both a weighted analysis, which was an imputation model, and a sensitivity analysis to account for a number of people that they unfortunately couldn't get outcomes for because of interruptions due to the COVID pandemic. But to sort of account and check the robustness of this analysis, they did use a sensitivity analysis without weighting. So moving to the results. So as I've said, they enrolled patients and participants between 2018 and 2019, unfortunately having to end the trial early in January of 2020 when COVID hit. So unfortunately, due to this interruption, while they had a plan to enroll about 10,000 people, they were only able to get 4,000, which is actually quite a large number of people in the short period of time that they had. So their modified intention to treat population was about 380 compared to the 960 that they had planned. And then again, unfortunately, due to interruptions by the pandemic, only about 70% of their modified intention to treat population had hard outcomes at the end of the data collection period. So the baseline characteristics of the population that they had was pretty well balanced. So the randomization worked very well. There wasn't any significant differences between the two groups other than a slight male predominance in the intervention group and some social grants in the control group. Otherwise, they were sort of very well balanced by age, previous TB, HIV, household income, employment, and education level. I did note that there wasn't any balancing or they didn't check to see if there was balance for disease severity, which is something that we see quite a bit in other TB clinical trials looking at treatment efficacy. And there's more and more sort of description around comorbidities like diabetes and tuberculosis, but unfortunately this data wasn't collected. So the most important result of this trial is that there was a huge reduction in relative risk in participants undergoing or participants who received the intervention package. So this is a relative risk reduction, so relative risk of 0.52, that translated to an absolute relative risk reduction of about 14% between the unsuccessful and successful groups. So this is in the weighted analysis group and people that they had endpoint, so they didn't have endpoint data for. And then they performed a sensitivity analysis as well, just to see whether or not this was a robust weighting. And they could see at the same time in the unweighted group that there was also this pretty big trend towards benefit in the intervention arm. And they also noted that the biggest improvement was in that pre-treatment loss to follow-up group. So comparatively, there was about a 10% difference in people receiving the intervention who actually stayed in through the diagnosis and initiation of treatment part. Notably, there was no difference between treatment failure and all-cause mortality. So interestingly, the other significant result from the trial was that in the regression analysis of different variables that might predict bad outcomes, it also revealed that other social protection factors, so such as food security and full-time employment, were also associated with better TB outcomes. So again, the relative risk is significantly reduced with those protective factors. Overall, I think that this was quite a strong trial. Like the methodology itself was quite strong. So it was pragmatic, real world, and randomized. They used allocation concealment and they blinded the data analysts, even though it was an open label trial and they couldn't blind the participants or clinicians. Comparatively to other randomized control trials and observational trials that have tried to look at this sort of socioeconomic bundle, there seemed to be high fidelity to the intervention. So they quoted about 93% of people actually were going to the ATM and getting money out, or they were able to tell via bank transfer apps that the money was actually going to the intended person. So this actually demonstrates the feasibility in low middle income settings, and something that we need to consider when building trials and programs. And it seems to be consistent with other observational studies that are happening at the moment in other areas such as India and Brazil, though these are sort of more observational than randomized data. So unfortunately, the main weaknesses of the study come out of the fact that it was grossly underpowered because of the COVID pandemic. And we can see that in the wide confidence intervals in some of the results. But the counter argument to this that was provided by the authors is that the actual effect size was so drastic that we think that they do think that there is a significant benefit. Unfortunately, because of the design of the trial, they excluded drug-resistant TB, and I think that more studies in this for this intervention would need to include such a big part of the tuberculosis problem. I think one of the major critiques of the study is that they use a package of interventions, so it means that you can't actually delineate where the biggest effect size come from, so financial or counselling, and there therefore is a role in future studies to look at multiple different arms and whether or not these have a synergistic effect on each other. I don't think it would also be very useful to consider different amounts of money being transferred. So they used a fixed value for all people, but obviously one amount of money can be quite different to one person and might have a different effect on one person than to others. And unfortunately, there was no cost-effective analysis in this study, but I did note that the authors were planning to publish something separately. And then speaking to the generalizability outside of South Africa, I think a lot of these socioeconomic bundles or treatment support trials really have to be specific to the area that they're in, because I think it's very difficult to generalize outside of different areas. So I think what we have here is a pretty good randomized controlled trial with quite a robust methodology that explores the socioeconomic interventions on TB. Obviously, the study had limitations and it was extremely underpowered, but it did show a pretty drastic difference in relative risk with the intervention package and that big effect on pre-treatment loss to follow-up. So not only is the primary outcome stark, but we can also see the importance of other social protection factors like food security and full-time employment on TB outcomes. So I think it really begs the question, if treatment support measures or socioeconomic patient-centered bundles have this sort of profound effect on TB outcomes, and we have global policy that is pushing for them to be integrated into research and national programs, how commonly are these interventions actually being incorporated into our clinical trials, and are they being described? So that's the question that we brought to the table, and that's something that we've been exploring in the systematic review that we've been doing for the last 12 months. We looked at late phase TB clinical trials that had been published since the introduction of that WHO and TB strategy I spoke about at the beginning. So we had a hypothesis that despite the introduction of this policy, TB trials are still really, really being dominated by that biomedical approach and adherence monitoring methods such as the directly observed therapy. And we just don't have that integration of more patient-centered or treatment support measures in both clinical trials and real-world programs. So I'll quickly speak to some of the methods. As I said, we only include late phase, so phase 2B and 3 TB clinical trials. We looked at both drug and non-drug interventions, and all trials had to have a primary endpoint of treatment efficacy. So that was defined by standard outcome descriptors, so sputum conversion, TB cure, TB relapse, treatment failure, death, treatment completion or success. We excluded non-randomized studies, and unfortunately we're unable to have a look at the ones not available in English. But overall, we were wanting to describe the frequency of treatment support in clinical trials and the quality of said reporting. So it's just speaking to what the trial landscape looks like in TB. Well, we're still mainly focusing on drug interventions, though I was surprised that about 30% of them were non-drug interventions. Importantly, most trials are occurring in the places where TB burden is the worst. So more than half of them are occurring in the African and Western Pacific regions, which is fantastic. What we did note was that, unfortunately, the additional information in trials was not necessarily available. So protocol supplementary information, it was only available in about half of the trials that we looked at. And then we also looked at sort of the number of trials that have been published over the last 10 years. And we can see that it hasn't really been increasing despite increasing interest in TB and increasing early phase trials. So that doesn't seem to be a translation between early phase and late phase. We saw a little bit of a sort of post-COVID spike, but that could have just been reflective of people finishing their priorities changing after the pandemic. So I guess we just wanted to quickly describe what treatment support looks like in TB clinical trials. So I've already sort of, as we hypothesize, the DOTS or treatment adherence methods seem to be pretty well established within TB programs, and they're consistently being included as part of the intervention package for biomedical interventions. But what we're seeing is very few clinical trials are actually integrating treatment support measures or socioeconomic bundles into their reported protocols. So what we can see in the ISMAIL trial is that, yes, data is increasingly suggestive that these support methods have quite a profound impact on TB, but our clinical trials either don't incorporate them into their protocols, which doesn't reflect global policy, or they don't report them. So which means that the interpretability of the data might be quite flawed. So either way, what we need is a paradigm shift. Instead of asking what drugs work best, we need to ask what systems work best. And recognizing that might lead to greater standardization of these treatment support interventions in our trials, and hopefully one day translate into real programs. And that is it. Thank you very much. Have you any questions?
I'd like everyone to join me in congratulating Beth on a wonderful presentation. It was crystal clear. And Beth has really driven this work in, looking at alternatives to what has been very challenging in TB, which is, finding new drugs, finding new treatment regimens, shortening the duration of treatment regimens, when we really could have a solution that's simpler, more accessible. Congratulations again, Beth. And I will mention that Beth actually got this, the systematic review is in as an abstract to ACTnet this year, but she pulled it because felt it would be better placed at the Union conference, where hopefully may have more impact. So congratulations again, Beth. Okay, shall we take some questions? Phil, I'll hand over to you if you want to take the first one.
Thanks. Yeah, there's a couple of questions in the chat. I might just pick on Alan Kumar. Do you want to actually ask your question, since you get the privilege, since you are actually a counsellor and a lead counsellor here in Papua New Guinea for a couple of programs? It'd be great. Do you mind, Alan? Oh, I might have caught you on the spot. I might get you to comment later then, if that's okay. But the question from Alan was, for the pre and post-test counselling in the study, is there any follow-up counselling? Was there more details, Beth, in the original paper on exactly how much counselling was involved?
There was nothing more in the primary publication other than the 15 minutes of pre-test counselling and then just a brief follow-up after the results came through. And that was the bundle that they offered only. I know that they had training of the counsellors throughout the trial or throughout the process, but they didn't actually see the patients and participants more than that additional sort of pre-post test occurrence.
Because there's also a question from Dr. Rondi Kauna, who I also believe is in Papua New Guinea and is a pediatrician, I believe, who posted a question before the session, but also in the chat had, is the TB counselling done by certified healthcare workers like for HIV? And it sounds like from what you said that there's training, but not necessarily certification to the same way that HIV has really formalized it. And it's interesting that, HIV has really made a strong push that counselling is involved in every HIV test, and ongoing counselling also available for treatment. So thank you, Dr. Rondi, a very good comment. There was also another comment about, I think from Dr. Rondi, which others won't see, but was a comment around how would this apply in a setting in PNG where there is maybe some law and order issues, and so trying to keep systems running when maybe the place is a little bit unstable. And maybe if I can broaden the question out, because I think it's a great question, I might comment on that. But first, Beth, how generalizable do you think this study is? Do you think we need to repeat this study in other countries, or do you think this is enough evidence to incorporate cash transfers?
I think you need to have a look at the different look at specifically different populations, and I don't think that this is necessarily generalizable. Although I think there's increasing data across the board. So there's some South American studies, there's studies in India, and there's there's a Peruvian and a Brazilian study as well that is also looking at it. And the outcomes are pretty positive. So I think while it needs to be tailored to the area specifically, I think that you need to have data coming from different populations to say what is actually going to be needed, because I don't think that we can just say that this is going to work for everybody.
Thanks, Beth. Maybe just a comment. In one program I was involved in South Sudan, they didn't do cash transfers, they did cow transfers. If you completed your whole treatment, you got a cow. So it may be different in different settings depending on what people value and want. But maybe Gail, I think there was a good question from Paul. I don't know if you wanted to bring that one into the...
Before I bring up Paul's question, I just wanted to say as well, the data, there's one other randomized control trial which happened in Peru from a group in the UK. This is, I've forgotten their name, but it'll come back to me probably.
I don't have it open.
And that it was a phenomenal trial where they showed that a social protection package that was offered. So it was a bit broader, the intervention, not just counseling or cash transfers, although those were included. It also included things like, groups where they would meet to sort of discuss what was happening in their lives, a support worker, employment. It was really a wraparound policy, and it showed huge improvements, not only in TB treatment outcomes, but also in the number of people who developed infection, latent disease, essentially. So suggesting that a package or social protection policies can even have an impact in reducing transmission. This was published in 2017. I think WHO Bulletin was the paper. So if anyone's interested, can look that up. As Beth has pointed out, many of the other interventions which relate to treatment support have not had good fidelity. So people haven't actually been able to get the intervention that was desired. They didn't end up getting the cash. So the outcomes from those studies, which weren't randomized control trials, they were largely ecological studies, effectively weren't impactful. But when you do sub-analysis, as they did in India, the people who actually received 5 or more cash transfers had hugely beneficial impacts. And I think this speaks largely to the fact that TB is a disease of poverty. And that segues very nicely to Paul's comment. It's a disease of poverty. And if we can really address the social determinants of health we would make a huge impact, not just on TB, but on many other diseases as well. So, Paul, I don't know if you're able to turn your, you'd like you to ask your question yourself, please. Oh, yes, Steve says it's Carlton Evans Group. That's right, Tom Wingfield and Carlton Evans. Thanks, Steve. Paul, yeah, go ahead.
Hi. First of all, Beth, thanks very much. That was a great talk, really interesting, and congratulate you on your work. I'm calling in from the Waikato. We've got quite a lot of TB, and Hugh McGann's also on the call. He manages that for us, but we try and keep across the literature, and we're very interested in the social determinants of all infections. We're very interested to read the Rations trial in India, which showed something like a very similar relative risk reduction in TB. I think it was household transmission, and also an index case mortality was affected by macronutrient interventions for all households in in block randomized or households with TB. My question was whether there was anything in the paper about what people spend their cash transfers on. I imagine if you're hungry, you spend it on food.
No, unfortunately, I didn't explore what was actually what they spent the money on. So that wasn't reported at all.
I wonder, Paul, do you think it would be important to dissect that and find out? I think Beth made a comment earlier, that it would be interesting to know. And I agree intellectually, it would be interesting to know whether it would be the counselling that helped more, and was it the pre-test or the post-test counselling, or was it the cash transfers that worked more? I have my own opinion about what I think would have had more of an impact. But do we really need to understand where the money is going or what it's being used for?
I think you put me on the spot. You could probably argue it both ways, and I've got two answers. I think that in most biology, things work as bundles. So, if you're managing employment and nutrition and issues of social protection and facilitating treatment, you'd imagine that all of the interventions together are greater than the sum of their parts. So that's one way of looking at it. You should just do whatever works. I think that regarding cash transfer specifically, and it's a terribly cynical answer, but I think you need to know what component actually works, because our current government don't like the idea of giving anyone money. So if it's money for food, then I think it would be more palatable to arrange food than to cash. And I think it's almost a political aspect to the answer, and that might make it important to know. That's just my off the cuff comments rather than anything that's had a lot of time to reason that through. But
I know that there's been some observational studies where they look at like providing a hot meal, for example, to people that come in for therapy, and that compared to a cash approach in like sort of mixed method studies suggested that people were more inclined to take the cash as opposed to just the meal. And if they're going to be traveling long ways and paying for the transport as well, that's where a lot of the preference comes from. And I think that this study, that the authors of this study really, they did explore it, and they said, we know that it's limited. We've chosen this fixed number. And the number that they chose was based on a 2013 study on what the cost of TB treatment was going to, at what it cost people. And I don't think they really accounted for the change over the last sort of 13, 14 years in terms of the cost of living. And they also didn't explore like the different, like what different amounts would mean to different people. So I think if that people are going to be doing more studies on this, it really needs to sort of just be, shouldn't just be a fixed approach to a single person. It should be, multiple sort of different price points. In at what point is there a saturation, or is it just continuing to be better with more amounts? I'm not sure. And how much can we actually afford?
I mean, maybe to jump in on that point, and in the MDR TB space, there's actually been quite a lot of programs incorporating various forms of support for patients. But the gap between how many programs have implemented either food programs or cash programs or other forms of support compared to the amount of evidence that's actually published as a study is huge. And which I think is interesting, and therefore a lot of programs may get good results, and it may or may not be due to the intervention. It's not well documented, and when the intervention comes to an end, it kind of stops because people are interested in cutting funding. But one thing I would say about food is it's just much easier to transfer cash, and otherwise trying to organize food and distribute food takes up a lot of time and logistics and cost in and of itself. And I'm not sure that it's actually any better than cash. But again, it's nice to actually see a study that does actually rigorously measure what difference cash makes. I do note that some people have commented it's very hard, having applied for grants, to look at TB treatment support. People are much more interested in funding new drugs or video observed therapy. But the amount of money in TB that's spent on directly observed therapy, either by people or by video, to this day is huge, and we don't have very good evidence that it actually works. I'll get off my soapbox. I'm just checking if there are any other comments or any hands up, and feel free if people do want to comment, because I'm sure the comments from the audience would be far more entertaining and enlightening than more from me.
Whilst we wait for a comment to come through, and please feel free to think of some, I was just reflecting as Beth was speaking on, how we, in the TB clinic that Phil and I work in here in Australia, in order to incentivize patients to engage in care with us and be able to actually make clinics, the TB program in Victoria actually provides incentivization via some form of cash transfer. So that, patients, for example, will get a taxi voucher if they struggle to be able to afford to come to clinic. That's what our program provides, because I feel very much that we do many things to support patients to be able to engage in programmatic care, and I think if that could systematically be implemented, whether it is here in Australia or whether it is overseas, I suspect that we would have much better patient-reported outcomes, not just these hard outcomes of do people not want to get do people survive from their TB illness, or do they complete treatment? Yeah. Okay.
I think it's interesting. Oh, sorry.
Sorry, I was going to jump in, and just before we'll get to your comments. But I was just going to jump in, and Frederick, I know you're on the line, and as you head the TB work that Burnett's doing here in Papua New Guinea, I wonder if you'd like to comment, given sort of some of the discussions around adherence support and counselling that we've had, and sort of some of the struggles. Do you think this paper is that encouraging us to implement cash transfers in PNG? Do you think that would be something that would be needed and improve things? But Beth, maybe your comment, and then Frederick can comment.
I was just going to speak to when you said that people are struggling to get grants for treatment support, as opposed to sort of the biomedical and adherence measures. Because if you had a drug that reduced the risk of poor outcomes in TB by as much as this, then people would be jumping to give money for more research and development. But I think it's hard to grapple with the fact that this is seemingly really, really effective, but not as important or interesting. It's more of a comment than anything.
Thanks, Beth. Frederick, are you still there?
Yeah, I'm here. Thanks. So in PNG, World Vision, as the PR for the Global Fund, has been pushing some patient enabling program, and that included not really an incentives, but actually trying to facilitate patients from going to and fro clinics. So it came in the form of financial assistance and also food packages as well. It did work really well when it happened, but actually, as any other funding, the funding comes to an end, and then that's when we actually had a lot of issues. So I think probably discussing any patient enabling programs, I think we need to also think about how well we can probably sustain that. I think working well with the government because these are people, patients who have TB are people that we are dealing with. Sometimes they do appreciate what we do to enable them to be adherent to treatment, but at times when such help comes to an end, that's when we have issues. I've seen people actually stopping treatment because they never got any support from that, and that's been a challenge to us. A couple of areas that we have actually, couple of areas where we had patient education and counseling that has really helped, and the patient enabling program sort of complemented that services. But in PNG, we continue to have challenges because patient counseling services is done through projects and done in certain areas. It's something that the National Department of Health tries to expand to other provinces, but it just doesn't happen with limited funding.
Thanks so much, Frederick. Probably, I think my last question, and then we might be moving towards wrapping up if there aren't any hands up. My last question is, do you think we need another study, or what would be the next study that's required in terms of treatment support? Or do you think we actually should start doing this and then see? And that might be for Beth and my co-chair and anyone else who wants to answer their opinion.
Phil, that's an excellent question to end on, but Taffy had his hand up, so I'd like to give him the opportunity, please. Go ahead, Taffy.
Thanks, Gail, and thanks, Beth, for the presentation. I think just to add on to what Frederick was mentioning regarding PNG, so in Daru, for patients that are on treatment, they access DOTS, but they also receive lunch, and that's served by World Vision at our DOT sites. So that's one, and this is just for patients on treatment. And at the end of their treatment, they also receive a voucher that they can take to the shops to access, to buy food and all that. So that's an incentive that is already happening in the routine program, but obviously it's funded, and that funding may actually come to an end, and hence the sustainability question that Frederick was bringing on. And I think, in general, we talk about nutrition, we talk about TB being a disease of poverty, and, fixing that, if it's at all possible, will definitely go a long way. And that also brings me to that study that was done, I think it was in India, the ration study, that also looked at providing, food to household contacts, and that's to prevent, as in, contacts of index cases with TB. If they are supported nutritionally and all that, that may actually prevent them from getting TB. So I think this brings to prevention, supporting, and also supporting those that are on treatment. So just a comment on those two aspects.
Thanks, Taffy. I think that, one of the best arguments Paul was saying before, that, the provision of food from the rations trial, which has been groundbreaking, really. Every TV conference I go to now has really got a special section that's just dedicated to food security for people with tuberculosis. And I think that says a lot. So we're slowly shifting away from the biomedical model. But one of the arguments, and this was several years ago, I think, and thanks to the rations trial, I'm hearing it less and less, is that if you cannot sustainably provide support to patients, then what you create is a situation of unfairness, and that lack of sustainability can actually disincentivize people from seeking healthcare. So they get angry about not receiving the incentives that were once provided to them, and they turn away or become disenfranchised with engagement with health, which is usually provided through some government body. And so at least that's the maybe poor argument people use to not wanting to either fund studies that are looking at alternatives to the biomedical model, or in fact just in programmatic care as well. But I think Phil asked a very important question. So Beth, you've read 70 trials on treatment support or looking at treatment support in the context of randomized controlled trials that have been performed over the last 10 years. What do you think we need to do to elevate the possibility of treatment support, or re-examining this question more thoroughly? What do we need to do? Do we need another clinical trial? And what would it look like if that was the answer?
So I think that this trial, obviously, the analysis is pretty incredible, and like the difference that it made to outcomes is huge. But it's so underpowered that I don't necessarily think that we can push this as push it by evidence. Yeah. So I think definitely we need something more multinational that is across multiple different sort of settings. I don't think that we can necessarily apply the same interventions in similar areas. Like, for example, I don't necessarily think it's going to work in Australia versus somewhere in South Africa or in South America, for example. But I think more sort of analysis on whether it's going to be cost effective is important, and then really looking into implementation analysis. And I think checking to see if these are actually feasible in national programs is something that needs to be looked at more closely, because it doesn't seem to be well integrated at all in any of the programs consistently anyway.
Thank you, Beth. We've got 5 minutes, so I'm going to ask everyone to please thank Beth once more for her excellent presentation. And it takes courage to be able to show up and present like this. So thank you, Beth, sincerely.